Hello, and welcome to the lecture on gastrointestinal disorders. Following today's lecture, you should be able to describe the differences between pediatric patients and adult patients in the design and function of the GI system. You also should be able to discuss the similarities and differences in structural, motility, inflammatory, and absorption disorders among the GI system. And finally, you'll understand the fluid requirements of children. The GI system functions the same across the lifespan. In other words, the GI system in the child does the same thing as the GI system does in adults. However, maturational differences come into play when we look at diet progression. The system is responsible for nutritional intake, breaking down of food, absorbing nutrients, and excreting waste products from our food. When we look at the pediatric digestive system, we notice that the stomach is much smaller than the adult stomach. This makes sense because as infants, we can only take a few ounces of milk. But as adults, we take in much more food and much more solids as well in our stomach. Another difference is intestinal motility. Intestinal motility is more rapid in pediatrics than it is in adults. Babies are really good at eating and pooping. This happens about every 1 to 2 hours. Therefore, it doesn't take them very long to break down something once it goes into the body. Versus adults, we could digest things over hours or days in length of time. Another difference is children lack the gastric enzymes to digest foods at birth. This is why we need to make sure we're progressing the diet appropriately, and it progresses from liquids to solids to a more regular diet as the child gets older. If we progress too quickly, then the child would struggle with the diet changes because they can't break down the food in the quantity and consistency that it is being received. Another difference is the liver. The liver of children is very immature, so many times we make special considerations of this when we administer medications, and if we have a disorder that could affect the liver adversely, then we monitor the liver function very closely. And finally, we know that by age 2, digestive maturity is complete. This age is important because it gives us a cutoff for our concerns. If a child is struggling with something after age 2, then it's usually related to a physiologic process rather than a maturity of the system. In any case, we're going to look to see what the cause of the abnormality is. This just gives us another avenue to look down. The first defects that we're going to talk about today are those that are considered structural defects. The first of these structural defects are cleft lip and cleft palate. These defects are when a bone of the palate or the skin of the lip and nose do not fuse during fetal formation. The causes most of the time are unknown, but seizure and diabetic medication, as well as environmental toxin exposure, are thought to contribute to these. It is estimated that 2,700 babies are born each year with a cleft palate, and 4,400 are born with a cleft lip. This can be with or without palatal involvement. This is actually one of the most common birth defects in the United States. It is thought that taking folic acid during pregnancy could help prevent cleft lip and cleft palate. However, we know that if mom has had a cleft lip or cleft palate repair themselves, then we will watch in utero and plan for correction if it needs to be made. Cleft lip and palate are differentiated by their location. The lip may involve the nose and one side of the lip. It's usually readily apparent at birth. Early closure of the defect would help with latching and using a bottle and being able to utilize the nipple. Cleft palate, on the other hand, is less apparent and may only be confirmed by manual palpation when we do the examination at the newborn assessment. Ultrasound or MRI can help with the diagnosis of the extent and help to anticipate and plan for surgical correction. Diagnosis is usually made at birth, on physical examination, or on a prenatal ultrasound. A cleft lip or palate can elicit an emotional response from the parent, depending on the severity of the defect. Nurses must be prepared to help families accept the child, the treatment plan and responsibility that goes with that child is important for the family to embrace as well. It might be necessary to get assistance from other departments or resources from the hospital to help families in this situation. Treatment generally includes surgical repair of the cleft. Surgical repair is not recommended until 3 months of age, making multidisciplinary support even more essential. The palate repair may not occur until 12 months of age to allow for developmental changes expected in the oral cavity up to age 1. Fortunately, we can do things in the interim to protect the palate and allow for feeding, as well as meet the nutritional needs of the child. As you might imagine, the defects can have effect on speech, hearing, and dentation. Therefore, treatment teams often include speech therapists, dentists, oral and plastic surgeons, ENT doctors. Social work and psychology may also be involved to help parents cope with the issue. Postoperative care should include cleaning the incision, avoiding stress on the suture line, applying elbow restraints, and just loving on that child. I want you to think about each of those things and think about why they're important. Cleansing the suture line is important to prevent infection. Avoiding added stress on the suture line will promote healing, and they will also decrease scarring as the child heals. The elbow restraints are something that have to be applied, and they keep the child from kind of pulling and messing with things, and they're something that are usually on all the time, because think about what babies do growth and development wise. They're always putting things in their mouth, so the elbow restraints help remind them that that's not a good idea right now. And then finally, TLC, or tender love and care, is something that we must make sure that we do for the child. Maternal bonding can be affected as we move into the post-op era. Eating is the biggest difficulty for these children. The defect makes it difficult for the infant to latch, to suck, or to swallow. We know that nutrition is essential to growth and development, so it's imperative that nursing care focus on meeting the nutritional needs of the child and the emotional needs of the family. Nursing support includes helping with feedings, educating families on the importance of using adaptive equipment, and frequently burping the child. You can see in the picture that a syringe is being used, and it has kind of a spout on the end to promote that child to take the milk and swallow the milk when latching is not able to be done at the time. This slide shows some additional examples of devices that are available to help a child with a cleft lip or cleft palate. You can see that the nipple has an adaptive device that allows for latching to occur, but allows it to occur deeper in the throat. The other device is a baby denture. It is used until the palate is closed, and this provides a mean of rigid support that's needed for proper bottle feeding. Think through your nursing care, and what do you notice about how this might impact care? What about parent education in regards to this device? We're going to have to consider things like denture care and cleaning that denture. Going to consider the size of the bottle and the adaptations that need to be made as growing and healing goes, as well as the emotional implications of having to use a device like that. Probably the most important thing that you can do for parents is to support the bonding process. Infants are mom's buddy. They need moms, and moms need those babies. The babies depend on mom for everything, from feeding and other needs that arise. And when moms can't do these things, as some of you might know, it can affect the maternal-child bond. Therefore, an important piece to the care is promoting bonding. Nurses can help mom feed the child in a proper way, maybe using one of those devices that was shown in a previous slide. Nurses can also encourage parents to talk about their fears and their concerns and their hesitations. Parents might fear what others will think of their child, and nurses can help with that acceptance and help the family settle into their normal as they wait for the cosmetic repair. The next slide shows some before and after photos of the repair. It is pretty amazing. The next structural defect that we're going to talk about is tracheoesophageal fistulas. These usually occur as a result of the GI tract failing to separate properly from the respiratory tract in early development. It is commonly associated with polyhydramnios or excess amniotic fluid. The reason this happens is because the child is unable to swallow and process the fluid due to the defect. That's why it becomes a symptomatology of the disease, because the baby can't process it the way it would normally. Tracheoesophageal fistulas, or TEF, is a disorder in which the esophagus ends in a pouch, and then it reattaches at a different point in the body, usually above the bifurcation of the trachea. These segments are usually connected by a solid cord. This is the most common form, and it's presented in 95% of these cases. If you look closely at this picture, what complications do you see occurring with the child? Definitely breathing and eating is a difficult task, if not impossible for this child. So you know it must be corrected quickly. There can be variations of this disorder. A child can have a double fistula, or two fistulas attaching to the trachea. They can also have a fistula without the esophageal pouch, which is called an atresia. They can have an atresia without a fistula, and then an unfortunately lethal condition called aplasia of the trachea, where the tracheal tract is not present at all. Many times these are noted on an ultrasound, an anatomic ultrasound that might be done in 20 to 26 weeks of pregnancy. However, when a child is born with this disorder, hopefully we can recognize it during the first feeding or immediately following birth. The child will present with vomiting or choking, drooling, cyanosis, apnea, or abdominal distension. The symptoms will depend on the extent of the defect. For example, if the child only has an esophageal fistula, they may only present with vomiting. But if the trachea or respiratory tract involved, then we may see respiratory symptoms also be present. But again, hopefully we can see this prior to birth and know that it's happening and get intervention before that first feeding. So as you can tell, surgery is a must for this child. The fistula or the atresia must be corrected so that the child can eat and breathe. The nurse should be concerned with airway patency, so the child may need to be suctioned to help with secretions. The child will be NPO and may be fed using other means when appropriate. Then they may progress to oral intake as they heal and a plan is made to compensate for the disorder. These children may have G-tubes in place, or they may have TPN, or they may have nasogastric tubes to help meet their nutritional needs. Pyloric stenosis occurs when there is a stricture or obstruction of the lower end of the stomach. This is not life-threatening, but it must be corrected to allow for absorption and processing of food. As a result of the stenosis, the muscles around the pylorus will hypertrophy, and gastric emptying cannot occur. Here is a better picture of what happens when pyloric stenosis occurs. As you can see, the muscles are enlarged around the pyloric sphincter, obstructing the emptying. Fortunately, this order is very treatable. A surgical repair of the narrowed area is accomplished by a small incision in the right upper quadrant of the abdomen. Then an incision is made through the muscle to relieve that pressure. Another option is a balloon and stent to narrow the opening. Depending on the surgical procedure, there may be incisional care that needs to be made. But regardless of the surgery, your treatment will be aimed at treating and preventing dehydration. Therefore, small feedings will be given in the postoperative phase, and then these are progressed as the body heals and the patient shows that he or she is tolerating those feedings. Positioning will be important as well, as we must keep their head elevated to promote gastric emptying and prevent aspiration. This could be accomplished using a car seat or maybe some type of a wedge to keep the head elevated. They will also have a focused GI assessment, along with daily weights to monitor GI and hydration status. The next slide shows an example of a corrected repair. In regards to the repairs, a pylorotomy is the surgical incision, and the pyeloplasty is the balloon and stent. Gastroesophageal reflux, or GERD, is a common gastrointestinal dysfunction noted in premature babies and associated with neurological disorders. However, any child could develop reflux as a result of a lazy cardiac sphincter. This relaxation of the sphincter causes the gastric acid to reflux into the mouth and GI tract. Unfortunately, children cannot tell us they have heartburn, so many times they present by spitting up and showing a trend of recurrent ear infections. If not recognized or treated, however, babies can develop aspiration pneumonia and apneic episodes due to the reflux. Management of this is important as well, because weight loss can occur if this is not treated. But first, it must be diagnosed. So this is usually done through an upper GI series to look at the sphincters and to grade the severity of the reflux. This series will look for GI damage that can occur from the acidic secretions. Medications might include a PPI or an H2 antagonist. However, home management usually involves thickened feedings to decrease aspiration and smaller volume of feedings to avoid overfilling the stomach. Once the medication begins to work and the child's sphincter strengthens as they grow and develop, then the treatment plan might be modified. However, complications of the disease must be monitored for, and a surgical intervention may be needed for severe complications. Intussusception is another structural defect that we can think about in the gastrointestinal system. It's an interesting phenomenon and occurs when one part of the intestine slips into another part. Usually this occurs at the ileocecal valve and involves the small intestine going into the large intestine. It's extremely painful for the child and is the most common cause of bowel obstructions in children. Due to its location, it can manifest itself much like appendicitis. However, symptomatology can help with a differential. Symptoms of intussusception involve pain, bloody stools, and there may also be a palpable sausage-like mass in the right lower quadrant. The child may also, in episodes of pain, scream or cry or draw their legs up. The pain is extremely severe and usually requires attention in the emergency departments. If intussusception is suspected, diagnosis involves an X-ray of the bowels and a barium enema. In 75% of cases, the barium will help correct the intussusception by pushing the area that's telescoped inside the large intestines out. However, if this does not occur, then surgery is needed to correct the problem. Intussusception can occur at any age, so the nurse will want to consider what pre-op and post-operative care would look like if someone would require treatment for intussusception. Depending on the age, may change how you explain things surgically and what you will need to do in detail to care for the child. Intussusception repair may also result in a colostomy if the intussusception is severe and necrosis has occurred. But most of the time, they can open the colon, take out the problematic part, and then attach the parts together. It'll be important for the nurse to educate the child and the parents on signs of complications after surgery, and then monitor them for risk of bowel obstruction due to the defect in the colon as it heals. Hirschsprung's disease is known as congenital megacolon. This child will present with a bowel obstruction due to the absence of parasympathetic ganglion cells in the bottom part of the large colon. In other words, there is the portion of the colon that atrophies because it doesn't have the cells that it needs to cause it to repeat peristalsis. The area above the atrophy becomes inflamed and enlarged, and stool cannot move through, and it obstructs or alters the output. Hirschsprung's disease is common in males and most of the times associated with Down syndrome. However, it can also run in families if other risk factors are not present. If you look at the picture, you will notice that there's a picture of the normal colon and rectum, and then beside it, there's the part of the colon that's swollen from the disease. If you look just below that, you will notice that is the aganglionic area. And that aganglionic area that kind of looks like a deflated balloon, that's where those cells are not present. So you can see that the issue happens above that area, and that's what causes the symptom of obstruction. 80% of children with Hirschsprung's present with symptoms during the first 6 weeks of life. If a large segment of colon is affected with the disease, then symptoms may present even earlier, like the first 24 hours of life. Symptoms of Hirschsprung's include no bowel movement in the first 48 hours of life. It could also include changes in stool where they appear ribbon-like, and you may notice there's a palpable mass in the abdomen because of the impaction of feces. The child might also have a pot belly or bloating and other signs of obstruction. A gastrointestinal assessment is important on these children because symptoms may vary with the amount of colon that is affected by the absence of the aganglionic cells. A barium enema, or a barium study, is used to diagnose this disease. The barium maps out the large intestines and illuminates structures and allows you to watch the movements of the contents of the bowel. Once it gets to the affected bowel, the picture will be altered. This may then prompt them to do a biopsy of the area and look for the Hirschsprung's disease or other causes of the obstruction. When they examine the cells under biopsy, if Hirschsprung's disease is present, they will notice an absence of nerve cells. In other words, there's no nerve cells equals Hirschsprung's disease. This biopsy can usually be done at the bedside since the infants are less than 6 weeks of age and no nerve cells are present in those areas. There's usually no pain associated with the biopsy. Surgical biopsy can also be done if there is a concern that a large amount of bowel is involved. It's important, though, to evacuate the bowel, so enemas might be used to facilitate this until surgical repair can be accomplished. Surgical repair usually involves a temporary colostomy. During this surgery, the affected bowel is removed. The healthy bowel then is exposed through the colostomy opening and allows for the rest of the body to heal and adjust to the repair. It may take a few weeks to get this regulated, as the bowel recovers slowlier when it's manipulated. The parents will need to be educated on colostomy care and reminded that this is a temporary thing. The child will then return to the hospital within a few weeks and have the colostomy reversed at a later date. Given the surgery, the child is still at risk for obstructions and inflammation postoperatively due to scarring, but it should resolve in the first year of life. The long-term outlook for these children is very promising, and surgical intervention is usually not needed after the initial repair. Hernias are defined as protrusions of an organ or a part of the organ through the muscle wall of a cavity that contains those organs. Most often, if identified in newborns, it's due to the failure of normal openings to close during fetal development. In other cases, and usually older children, it can simply be due to a weakness in the supporting muscles in that body cavity. Hernias are usually visible when the pressure in the area of the hernia increases. In other words, when the child strains or cries, the hernia might be visible as a protrusion in the groin or around the belly button. They can be serious, but in most cases, hernias come in three types: umbilical, diaphragmatic, and inguinal. The umbilical and inguinal hernias are the most common and usually nothing to get too excited about. However, a diaphragmatic hernia, or when the organs of the abdomen protrude into the thoracic cavity, is a serious and life-threatening condition because the pressure changes and the position of the infant could cause respiratory issues. The risk of incarceration is also high in these types of hernias. Umbilical hernias are the most common type of hernia that occurs in children. As you can see from the picture, the bowel protrudes through the umbilical opening where the umbilical cord was once attached. It's common in preemies or children that have had low birth weight, but can certainly happen in any child. It usually is a soft mass that can be pushed easily back into that opening. Some of you may have heard that parents try to manage it at home by putting a tape or a coin over the hernia to help it to reduce. However, your book states that this is not an intervention that is evidence-based, and it is not the most effective way to reduce this. So we should encourage our parents not to use that as treatment modality. However, the most effective method is either spontaneous resolution by age 1 or surgical intervention. Surgical intervention for umbilical hernias are usually required if the defect enlarges, if it shows signs of strangulation or incarceration, or it does not resolve by age 5. Inguinal hernias are defined as painless inguinal or scrotal swelling that occurs when the abdominal tissue extends into the inguinal canal. Parents usually report a bulge in the groin or note the swelling in the scrotum when the child cries or strains. It is usually treated surgically because it does not resolve on its own, unlike umbilical hernias. Parents need to be educated on the symptoms of strangulated hernias so that they can monitor the status if that surgery is delayed. Symptoms of strangulation include nausea, vomiting, abdominal pain, bloody stools, a blue or a red change in color to the hernia itself, and irritability. You must know that it is a medical emergency and it requires immediate surgery to prevent necrosis of that tissue. However, a non-emergent surgery is usually done shortly after finding the hernia, especially if it's found after 3 months of age. Nursing care for hernias involved wound care, infection control, and pain management. If it is a diaphragmatic hernia, it is usually repaired immediately, and stay in the intensive care unit is mandated due to respiratory risks. Appendicitis is an emergent condition that occurs in adolescents and young adults. It can occur at any age, but the group that is highest at risk is adolescents. Typically, these teens come to the emergency room complaining of right lower quadrant pain, especially upon palpation or pressure. That finding is called rebound tenderness. The pain itself has a very distinct pattern, which involves periumbilical pain, and then it localizes to that right lower quadrant. The abdomen may also be rigid, and the patient might guard the abdomen. They might also have nausea, vomiting, diarrhea, and chills. However, the pain doesn't let up, and it tends to worsen throughout the day or throughout the time in which the phenomenon is occurring. The biggest risk of this condition is rupture, as the appendix becomes inflamed, infected, and swollen. In 25% to 35% of pediatric cases, there is a mixed diagnosis of appendicitis. So, therefore, the assessment becomes important so that you can monitor for complications. You can do this by conducting a thorough abdominal exam, including palpation by a doctor, and examining laboratory values and diagnostic data to determine the appropriate interventions. You might hear the term McBurney's point. This is where the area of pain is the most severe after palpation. When McBurney's point is compressed and released, the patient experiences a sharp surge of pain. If appendicitis is suspected, it will be confirmed by an ultrasound or CAT scan, and then the determination for surgery immediately or surgery later is based on the symptomatology and diagnostics. This patient may go to the peds floor overnight and then have surgery in the morning, or be sent there postoperatively to recover. Treatment regimen includes putting the patient in PO, preparing for surgery, and administering antibiotics. If rupture has occurred, however, the hospital stay is much longer than the traditional 24 hours, and the patient is treated with a more extensive type of surgery. However, if there is no rupture, the patient traditionally stays about 24 hours and is sent home using ibuprofen for pain and little restrictions. Wound care would be needed for small puncture wounds or a small incision. The biggest risk of appendicitis is rupture, as the appendix becomes inflamed, infected, and swollen. The initial workup in the ED should include a CBC. If the white count is greater than 15,000, then a suspected perforation of the appendix has occurred. In addition, a full rupture might occur if symptoms suddenly resolve. For example, if your patient is having a ton of pain and then all of a sudden they say, "Oh, that pain is gone." That is highly suspicious for a rupture. If a rupture occurs, peritonitis can result because fecal matter and bacteria mix with the peritoneal fluid. This is an emergent condition because the patient can quickly develop septic shock. In addition to surgical debridement of the rupture, patients will have a larger incision. They may have an NG tube to rest the bowel, a JP drain to drain abscess or infection, and require several days of IV antibiotics, potentially per central line or IV, to treat this serious condition. Recovery can also be painful, so therefore opioid is used in these cases. A morphine or fentanyl PCA might be the mode of choice should the patient be mature enough to use it properly. Gastroenterosis is an inflammation of the stomach and intestines that is often accompanied by diarrhea and vomiting. Many times it's caused by a virus, a bacteria, or a parasite. However, in some cases, it's a chronic problem associated with illnesses like colitis, short bowel syndrome, or food intolerances. Common causes are listed on page 1348 in Table 51-2. Rotavirus is the leading cause of gastroenteritis, but the incidence of this cause has decreased since vaccination for rotavirus has been integrated into the vaccine schedule. Even though there is a vaccine, however, it can be a major problem in countries throughout the world. It's extremely contagious, and often fever, vomiting, and watery diarrhea are the symptoms a person presents with. Children have multiple watery stools per day. Therefore, nursing responsibilities would be monitoring for dehydration, rehydrating if possible, placing the patient in contact isolation, and utilizing medications to minimize or stop the vomiting, diarrhea, and fever. The biggest complication of gastroenteritis and rotavirus is dehydration and electrolyte imbalances. Therefore, the treatment involves infection control to prevent transmission of the virus. Fluid and electrolyte replacement would be important to replace any loss that has occurred. Management of diarrhea to correct the cause and stop further loss, and replacement of lost bacteria. In other words, we would be prescribing some type of probiotic to help with that. Patients may be asked to follow a BRAT diet, and a clear liquid diet should be encouraged, such as Pedialyte to help with oral rehydration. Labs will also be monitored as well to assure the patient has not developed a sodium or potassium deficiency. The other thing that we watch very closely on children is weight. With mild dehydration, the weight decreases initially, and everything else seems normal. As the dehydration progresses, the weight loss increases, and more symptomatology becomes about. So weight would be something we would monitor, as well as daily INO. So why is dehydration so common in children? Did you know there are 1.5 million cases of dehydration managed each year? 220,000 of these cases require admittance because of its severity. Dehydration occurs for many reasons, but it's important to understand why children develop it frequently and why it is essential to correct it properly and efficiently. At birth, 90% of a child's weight is made of water. This is decreased to 60% by age 1, and it remains steady at this level through adulthood. In addition to this, children have a higher body surface area that predisposes that child to an increased incidence of insatiable water loss. This insatiable loss could occur with fever, it could occur with extra activity, but children's bodies are unable to compensate as quickly as maybe an adult body would. The other complication of dehydration is compensation, or maybe inability to compensate. Children's kidneys are not mature until age 2. Therefore, they cannot conserve water and electrolytes properly. Children depend on oral rehydration as well as IV resuscitation when dehydration is suspected. The other thing to note is the most earliest sign of dehydration in children is a weight change. The other things that we look at, urine output, urine-specific gravity, those types of things, the child small enough would be unable to compensate for those things using those symptomatology of low urine output, urine-specific gravity. In the early stages, there would be no changes, only that of weight. 3 types of dehydration occur in children: isotonic dehydration, hypotonic dehydration, and hypertonic dehydration. The first two are commonly caused by diarrhea and vomiting. However, it is important to recognize the clinical signs of dehydration so that you can intervene properly. It also helps to determine if hospitalization is required or if this can be managed at home. Dehydration ranges from mild to severe. Mild dehydration occurs when the child has lost up to 5% of their body weight. Sometimes they may be restless and they may be thirsty, but otherwise they seem pretty normal and their perfusion status is normal. However, as the dehydration progresses, the child loses more weight and shows more signs of a dry and poorly perfused system, such as a rapid pulse, delayed cap refill, sunken eyes, dry mucous membranes, absence of tears. If you see someone in this state, it requires immediate intervention and consideration of a pediatric emergency becomes an option. Hypovolemic shock is a state of imbalance in the body whose cause is a defect in fluid volume. Typically, hypovolemia is either hemorrhagic, caused by blood loss, or non-hemorrhagic, caused by fluid loss. Generally, if we treat the cause of the shock, it will begin to resolve. For example, hypovolemia caused by diarrhea may correct by fluid replacement and providing antidiarrheals to correct the causative agent. Symptoms of hypovolemic shock in children can vary depending on the severity of the shock and the degree of compensation that has occurred. Common symptoms are lethargy, dry mucous membranes, absent tears, tachycardia, hypotension, dark concentrated urine, a decrease in wet diapers, sunken eyes or fontanelles, hyponatremia, increased BUN, and decreased serum bicarb. Capillary refill can be compromised if compensatory mechanisms begin to fall. Other symptoms are listed on the next slide. Correction for hypovolemia involves oral and intravenous fluid resuscitation. Common oral rehydration solutions include Pedialyte, or a solution composed of water and electrolytes, including sodium. Ingestions of these solutions are weight-based and may be ordered following each stool or episode of vomiting. In order to comply, it might be necessary to add one or antidiarrheal medication or adding an antiemetic so that the fluid stays within the system. The amount of fluid that this child consumed might be increased as the child progresses and improves, and eventually the traditional diet can be resumed. Sometimes oral hydration or oral rehydration is not enough, and we must get intravenous fluids involved. IV fluid resuscitation may begin with a simple fluid bolus. This is a specific amount of fluid that is weight-based and given rapidly over 5 to 20 minutes. The amount and rate are, again, based on the weight of the child. The types of fluids that will be based on the electrolyte imbalance and the type of fluid loss. Most commonly, however, an isotonic crystalloid is given because it restores water and sodium loss. As the child begins to excrete that and show signs of improvement, then corrections to the electrolyte imbalance may occur. If the hypovolemia is caused by a burn or diarrhea is severe, then lactated ringers may be used instead of normal saline. D5W can also be used but must be cautiously monitored. It may help in situations where there's a known metabolic need. Fluids continue until the child shows resolution of symptomatology and evidence that the urinary system is working properly and showing signs of rehydration. Gastrointestinal parasites can be common in children. These can be obtained due to daycare use or simply playing outside, or you can have fecal-oral contact. One of the most common parasites is a pinworm. The pinworms will get into the GI tract and lay eggs in or around the anus. This causes the child to have an extreme itching around their anus. These worms become very active at night, so therefore a parent can inspect the anus at night via a flashlight to visualize any worms. Or a more common diagnostic indicator is the tape test. Upon rising in the morning, a parent would put tape on the anus, and this would need to be done before they go to the bathroom or clean at all. Upon removal of the tape, the eggs or maybe even the worms will be visible by eye or by microscope. The treatment is medication, and usually the medication is just one medicine, 2 doses, 2 weeks apart. In addition, household members are to be treated as well. So thank goodness that it is an easy treatment and easy resolution. But think about what nursing responsibilities might go with that. Depending on the age of your child, it may be difficult to obtain a diagnosis. Responsibilities would also include parents being educated and bringing other family members in to receive the medication. Currently, you can get this medication either from a prescription from your doctor's office, or it's something that can be purchased over the counter for treatments to be effective. The next several slides, slides 51 through 54, cover lactose intolerance and celiac disease. These are disorders that involve the inability to digest foods and ingredients in foods. Celiac disease is the inability to digest gluten. If a gluten is ingested in this patient, they usually develop diarrhea and abdominal pain. However, it can also be serious enough that they would develop an iron deficiency and growth impairments because the body isn't getting the nutritional items that it needs to fuel growth. Gluten is found in items such as wheat, barley, rye, or oats. This is why many pediatricians recommend starting with rice cereal rather than oatmeal. The treatment for celiac is usually a diet modification and the elimination of gluten. It's the same concept if a child would have lactose intolerance, but with lactose intolerance, then a medication like Lactaid can be given prior to meals to help with the digestion of the lactose. These patients may actually be able to enjoy some dairy products versus someone with a celiac disease needs to avoid them completely. Any age group can develop either disorder. What challenge do you see among each group when dealing with these diet modifications? The final disorder that we will discuss today is encoparesis. This is a phenomenon that occurs in children when they ignore the urge to defecate. Children do this for various reasons, but research shows that the most common reasons are stress, a response to stress, or, in many cases, a response to abuse that is occurring within the child's life. Failure to defecate results in constipation, pain, could develop fissures, definite rectal enlargement, and stool leakage. The treatment involves correcting the cause and then reestablishing a toileting routine. The nursing care is going to be approached sensitively in this situation. It also may take some time for full resolution of the situation to be resolved. And not only you have nursing care to help with constipation and relieving the constipation, but you're also going to do a multidisciplinary approach to help the child deal with the trigger, deal with the stress, or certainly the abuse that is going on within the home. However, the ultimate goal is to correct that cause and establish that toileting routine so bowel evacuation can occur normally. Thank you for taking the time to listen to this lecture. I'd like for you to just take a few minutes to write down a few questions that you might bring to class for clarification. We will discuss these answers at the beginning of the next class meeting.